Morning and welcome to the Board of Health online meeting and online viewers to the July 2nd meeting. The board meeting is officially called to order at 8:01 a.m. This virtual meeting is being streamed via YouTube, and this offers the ability for people to comment and also to serve as a repository for all meetings in case anyone wants to have access later on. This will be rebroadcasted on Facebook as well. So I'm afraid we still don't have quorum. Arlena?
No, ma'am, we do not, but I am
Okay.
reaching out.
So we will proceed with our business. The October meeting was rescheduled from October 1st to October 8th, just to follow up the fall break for JCPS. And next month, August, the Board of Health meeting has been canceled to observe summer break for the board. As June 11, there was a substitution for the whole advisory committee to the immunization practices. All 17 members were let go, and we have now a new committee, advisory committee. This has caused some concern for infectious disease specialists, since the recommendations that are going to be made by this committee will affect the access, not only the recommendations, but the access to the vaccines for our kids and the kids in the future. So let's just keep on advocating for vaccines. And as June 30th, or the CDC as June 24th reported for the measles outbreak, 1,227 cases. The majority of them are under 19 years of age, and 95% of these cases that have been verified are unvaccinated or unknown individuals. Only one has had the history of MMR. And what is concerning is that the vaccination coverage for U.S. kindergarteners has decreased from 95.2 during the school year 2019 to 2020 to 92.7% coverage in 2023-2024. What this means in real numbers is 280,000 kindergarteners haven't received their vaccines, and this represents a higher risk for them not only to get infected, but to suffer the complications. As of yesterday, 5 cases have been reported in Kentucky, and 3 in the same household, 1 and 2 more in 2 different counties, and at least 4 of these cases have been demonstrated that are unvaccinated. So this is an invitation for the whole community. If you have younger kids at home, please remember vaccines are safe and they are important for their safety and for their well-being. Just talk to your pediatrician and let's everybody vaccinated. Our perspective session for this month is presented by Dr. Nancy Seay. She recently became the dean for the School of the School of Arts and Sciences for Simmons College. The title for this meeting is Initial Findings from the Universal Basic Neighborhood Study and the New Directions They Are Taking with this concept. Dr. Seay is a renowned academic sociologist and researcher. This study, the Universal Basic Neighborhood Study, is a Robert Wood Johnson founded study in collaboration with Simmons College of Kentucky, Dr. Ted Smith, the current director for the Center for Healthy Air, Water, and Soil with the University of Louisville, the School of Medicine, and the Environment Institute, the University of Kentucky, and Rice University of Texas. The Universal Basic Neighborhood, or UBN, is inspired by the concept of a form of a universal basic income, financial support provided by government in the form of standard recurring payments to individuals without the need to pre-qualification. Today, I present to you Dr. Nancy Seay. Welcome, Dr. Seay. If you have your presentation, please go ahead, and if you would like to share it, and you may do that at this time. I yield the floor to you.
Okay, let me see. Good morning, everyone.
Morning.
Is it shareable, Arlana? Okay.
Yes, ma'am. I can pull it up and share it. Yes, ma'am.
Okay. Well, good morning, everyone. And it's really good to be back again. I shared with you nearly 2 years ago at the beginning of our study what we were trying to accomplish. And now here we're reaching we have completed at least this part of it. And we just want to share a few of our findings. I'm going to ask.
Dr. Seay, it is telling
Can you
me
hear me?
that, yes, ma'am. Dr. Seay, your presentation is telling me that it is too large for me to share.
Oh, can you share? Can I share the? Can you share the screen? And let me share what I have.
It will not allow me to share your presentation. When I click on it, it is stating that it is too large for me to share.
Okay, can you give me permission to pull up my own?
Yes, ma'am, you have permission. Yes,
Okay.
ma'am.
Thank you.
Okay, can everyone see this okay?
Yes.
Yes, ma'am.
Okay.
You just have to make it bigger for presenter.
You know what? Let me go
It's
back.
okay.
I'm going to stop sharing this. I had another version. And so sorry about this. Let me go back
No
and
worries.
find where I am. Okay, well, of course.
We were able to see the one that you previously pulled up.
Try to use the previous one, Dr. Seay.
Okay, yeah. The problem is this one. Okay.
There you go.
Okay, and this one is, let me see. Wait a minute. Here, that's a little bit better, isn't it?
Mm-hmm.
Okay,
You
well,
can
anyway.
go to the presenter. If you click the presenter, it will just open for you.
Okay.
Top right.
I'm trying.
One more above. 2 away from the brown click on your top right. There you go.
Okay, now full screen here. Okay, how's that, everybody?
That's fine.
Great.
Okay,
Thank you.
great. Thank you so much. Well, let's just get right into this. This is a collaborative research that we've done on the Universal Basic Neighborhood. It was collaborative, it was multidisciplinary, multi-frameworks, and we'll talk about that later, as well as cross-cultural, as we looked at what is a universal basic neighborhood. And, we talk about it, that it's comes from a strength-based and an anti-deficit way of thinking with our framework, that we go into neighborhoods expecting to find strength, resources in every neighborhood. The second thing is that it was, like I said, mixed methods and also multi-methods, as we try to have as large a bag of evaluative tools as possible to try to understand this huge concept. What is a universal basic neighborhood? And then the focus, as we said before, is on whole neighborhoods rather than on individuals. Often, we think it sounds nice to say, hey, we're going to heal this neighborhood one person at a time, but that's really not realistic. And we know that people experience health benefits as well as health risks as groups in defined spaces. And so our thesis is that it's better to treat whole neighborhoods if we want to see whole neighborhoods experience better health. We acknowledge the universal are the social determinants of health and their use for promoting good health among all people. However, we want to take it a little bit further when we're evaluating neighborhoods, because often social determinants of health look on an individual basis, or at least apply to individuals. And we're saying, well, what happens when we take this and apply these concepts to whole neighborhoods? Now, this is the basic universal basic neighborhood framework. While all neighborhoods we believe that all neighborhoods have health promoting qualities, they have resources. In the same way, every single neighborhood also has some health deficits. So our job then is to look at it and to understand that all neighborhoods have these different qualities, but in different mixtures. And so I like here at the model, at the bottom, we see that no neighborhood is without resources. They might have fewer, but they have some. And on the other end of the scale, there are no neighborhoods that are have everything they need, that are without health risks. And that's the way that we went into our study, enabling us to look at each neighborhood for itself. And we did evaluate 2 different neighborhoods. Now, the other thing is that as we're looking at neighborhoods, that our study touched on every ecological level. And so what usually, in Brofenbrenner's model would be the individual, where we have the individual neighborhood, whole neighborhood. And we looked at those things in the city, the surrounding city, that ecological level that impact neighborhoods. We looked at the federal and the state level of what impacts neighborhoods. And at this level, of course, it's generally policy. And then we looked at international and national frameworks for addressing health, touching health back here at the individual neighborhood level. And once again, this was collaborative. We had Simmons College of Kentucky, the University of Louisville, the Baker Institute out in Texas, and the Rosenberg College of Law at the University of Kentucky. A pretty wide and diverse team, bringing a number of different perspectives to the study of neighborhoods. Let's look at the major activities that were performed. We evaluated the health-related factors and frameworks that investigate health and how it's connected to place. This is primarily University of Louisville. We'll talk a little bit more about each of these. Then evaluate 25 years of neighborhood plans and how, to which degree were the plans implemented, particularly focusing on those that touch neighborhood health. And then conduct a legal and policy review of what does health policy look like, and what are those that are most successful in advancing health for neighborhoods. Conduct a rigorous IRB-approved qualitative field study. And then finally, conduct a comparative analysis of two Louisville neighborhoods. And the neighborhoods we looked at were Russell neighborhood in Louisville's western region. And then we looked at Crescent Hill neighborhood. These two neighborhoods were chosen because they were comparative in size, but they were also chosen because they were so different. Russell neighborhood, as you know, is predominantly Black and predominantly low income. On the other end of the spectrum, Crescent Hill neighborhood is predominantly white and predominantly upper middle class when it comes to income. And how do these different qualities shape neighborhoods and shape neighborhood health? Now, first, let's look at some of the things that U of L did. And I'm going to ask Ted, we were co-PIs, to jump in here and explain some of the things that U of L did. Ted, do you mind doing that for me?
I don't mind. Can everybody hear me okay? Great. So, some of the inspiration of this work, as Nancy said so well, is, reframing away from the individual towards the place-based health. And I think we all recognize that the great work in the social determinants of health, which is now, 2 decades old, really started that conversation, health outside of the healthcare setting. But if you revisit the origins of that research when it was started, what you'll learn is that very early in the process, there was a sort of a winnowing of the list of factors that were in places. And we all know, most common, you'll hear about housing, food security, and transportation. And those are obviously very important things, but there's a much longer list. And so what we did is we went back to all the administrative data sets that originally were used to inform the social determinants of health research, and we brought all those data types back into play, if you will. And so our team focused on all the known administrative data that is available at the census tract level, which is a trick in its own right. A lot of that work, as you probably know, was done at the county level for the social determinants of health. It was based on the county health rankings originally. And so we went through all of these different available data sets. It has to do with crime, and it has to do with transportation, and it has to do with the number of services, the number of community centers, the number of Superfund sites nearby, all kinds of data sets. And our team, really called that down, backed it into the literature, which of these things have any relationship to health outcomes, and attempted to come up with some scores and some sub-indices for each of these two neighborhoods to point out areas that residents may be aware of and are considering important to their community, and also point out some areas that the data would suggest are important to health status, but might not be necessarily top of mind for residents when they're thinking about their neighborhood plans. So that's sort of a quick tour, but it's an awful lot of data. Now that we're in the age of AI, we're about to go redigest it using some of those tools. It was a very basic ground up statistical process as we did it. But lots of factors. I don't blame Nancy for not wanting to drag you all through a lot of that in detail. Happy to follow up with anybody about some of those specific factors that were associated in each of these neighborhoods at any time. Back to you, Nancy.
Okay, thanks, Ted. And here's the evaluation from the factors. And it kind of lets you know that we have both neighborhoods, but neighborhood 1 is Russell and neighborhood 2 is Crescent Hill. Now you see both neighborhoods have resources, but in different measures. And that's what we're getting at. And so it was important that we didn't compare neighborhoods to each other, but instead compare neighborhoods to what we would have called to its own best potential. And we'll talk a little bit more about that later. The second activity was a legal review, and that's our friends at University of Kentucky, Shivani Carthens carried out this study. The problem, comprehensive planning laws have become disconnected from public health origins, right? And think about that if you think about the historical past of health policy. Our policies often was to address health problems. And so she did phenomenal work, and I'm rushing through this because I'm way over time. Here's some recommendations that came from her work. And I think we have a few more at the end. Mandate health-based data in planning research, that we can't divorce health from planning. And then legally empower the comprehensive plans. Shivani looked at plans all across the United States, and you can correct me if I'm wrong, Ted, but I think she only found 2 states that mandated that the plans had to be carried out. And everywhere else, it's like you have these plans that you put together, and they're like, well, strongly suggested. And then require meaningful public participation, including the lived experience of the residents for whom these plans are designed. And too often, the people are left out of the planning process. And then she says to use these comprehensive plans. Those are just a few. Then Ja'Cory Arthur, who was at the time our city councilman for one of the districts, he did the 3rd study, civic investment. And I mean, he poured through 25 years of plans, those local neighborhood plans, to see the degree. And that was also painstaking work because he had to piece together so many different documents. And he centered on our 2 neighborhoods, but he actually looked at every neighborhood back to 2000, every neighborhood plan, and then had to sift through like the dusty archives. And some of his findings, no surprise, uneven investment, implementation gaps, that always implemented in this. And of course, some of the neighborhood plans were newer than others, and he acknowledged that as well. Specific to Russell, that historic disinvestment, Russell is getting a lot of investment now, but that compounded historic disinvestment has led to higher pollution, higher housing insecurity, and public safety concerns. And then the lack of transparency. And when he talks about lack of transparency, it's not like the city is conspiring to keep information back, not in that sense, but the lack of transparency was in the difficulty that you have in accessing these public records. He suggested all of these neighborhood plans, all of the public records that are that have to do with the neighborhood and plans, including the funding records, need to be digitized so that they can be more easily accessible, providing greater transparency for people who really want to know how the city funds are being used for the recommendations of neighborhood plans. Fourth, and this was what I did, no, this is what Michael Emerson did. His role on the UBN team was to conduct an extensive data analysis comparing the project's study neighborhoods, searching for markers of the universal basic neighborhood. And he also does this in part by drawing on his understanding of healthy neighborhoods globally. He supports the project's methodological rigor and contributes to the collective visioning of our team. And basically, Michael, he sat in with all of us and did contribute, but he wrote an article, published a book article. He hasn't published it yet because he's searching for the right publisher, journal. But he brought all of what we did together to, number one, to make known the work that we're doing in the universal neighborhood, but also to actually make a comparison of these neighborhoods, incorporating our universal basic neighborhood concept. And this is just a line, a little paragraph in his proposed journal article, and I like it. Our methodological approach is grounded in the belief that it's insufficient to merely compare health inequalities between neighborhoods. And that's what we've been doing. Directly ranking neighborhoods against one another, particularly by contrasting the less resourced areas with affluent, predominantly white communities, can be misleading at best and harmful at worst. Such comparisons risk reinforcing the idea that affluent neighborhoods are the gold standard, overlooking the fact that these neighborhoods may also harbor liabilities that detract from the overall neighborhood health. Instead, we argue that more meaningful insights emerge when neighborhoods are evaluated in relation to their own potential, what we refer to as their best selves. And we thank Ted Smith for really bringing that home to us and even coming up with that idea. One another, but to their best selves. And then the fifth, and this is what I did, me and my friends at our team at Simmons College of Kentucky, we did neighborhood surveys, door-to-door surveys, focus groups, then key informant interviews. Then we brought all of our friends together twice, once in Crescent Hill, once in Russell neighborhood, to report back to them our findings. And this fourth step, the neighborhood report backs, proved to be really, really helpful because they added context to even the things that we had found. And just a little sneak look at some of the things that we found. One of the questions we ask in the focus groups, as well as the key informant interviews, what is your vision for your neighborhood? You know, we wanted to find what they aspired, that aspirational, how did they see their neighborhood at its best self? This is Russell. And then we asked the same question in Crescent Hill. The thing that we found out is that both neighborhoods basically wanted the same thing. That just because one neighborhood was poor and Black and the other neighborhood was more affluent and white, they still wanted the same thing in different measures. Russell saw crime and neighborhood violence, things that will hinder them. But many of the neighborhoods said that our residents in Russell said that even though we acknowledge that there's crime in our neighborhood, but we also acknowledge that we don't have to be limited in our neighborhood just because the crime is there, which I thought was pretty cool. Crescent Hill neighborhood turned out to be a very kind and giving neighborhood. They were very pleased and understood that they had a lot to offer, but they also expressed a willingness to want to share. And sometimes they even said, we want to share what we have with Russell, since they knew that these were the two neighborhoods.
You have 2 minutes, Dr. Seay.
Okay, let me go on to the end then. Recommendations for the state, recommendations for Louisville, University of Louisville came up with an action plan, and you can ask for these later. I want to end on a happy note. We fed into AI some of the things that the people said in the neighborhood when they talked about what's your aspirational neighborhood. Well, this is what Russell's aspirational neighborhood looks like. It has easy access to fruits and vegetables, lots of walking areas. They said they wanted places on the front porch, where they could watch their kids play and communicate with their neighborhoods, and especially places set aside for just visiting one another. They wanted a more social cohesion. Crescent Hill, do not ask me why AI put that Ferris wheel in, that they felt like Crescent Hill needed a Ferris wheel. I couldn't get it out. But see, Crescent Hill kind of wanted the same thing. They wanted even more walking space. And then somebody said maybe a trolley that would speak to some of the congestion there, I think along Frankfurt Avenue. And they were especially concerned that for safety issues for children that were going to school. Listen, thank you very, very much. Sorry for taking so much time. That's, I guess, the preacher in me. I got to share more. So if there's any questions, please let me know. Thank you so much for this opportunity. I'm going to stop sharing now.
Thank you, Dr. Seay. Thank you, Dr. Smith, for sharing with us your findings, and most of all for this presentation. And just, I love the way that you end up this. Each neighborhood should strive to be better by itself, comparing with their history. And the walkable city just resounded with the changes that are happening in our city. Thank you so much. Do we have any questions from the board? Ms. Margulis? I think you're mute.
You're on mute.
Okay, how's that? This will be very quick, just 2 sentences. Was there anything in this report that surprised you or the team that you didn't know? Just 2 sentences.
I'll take a stab at that. So, I said we used all these administrative data sets, and that includes things like park space and all that. When you look at Crescent Hill, there are not that many technically defined parks, right? But there's a lot of green spaces, right? The water company has a giant campus over there, and so the neighborhood really values. It's one of their strongest assets, according to that, right? Like we have all these green spaces, yet you would never figure that out by looking at all this administrative data, right? You would only figure that out by talking to them. Like, well, what do you mean? Where do you go? What do you use? And so I was struck by the fact that we may be missing some important parameters in places by not actually spending the time with the residents to really understand the lived experience in those places.
Thank you. That's perfect. And I assume you all will do that going forward.
Great point.
Perfect.
Thank
Thank
you.
you.
Anybody else? Any other questions? If not, thank you so much. We would appreciate if you can share your findings through your slides so we can go back and review, and also share. You know, this brings to mind Dr. Smith has been an advocate of sharing the results of the researching that is going on in the city with the people that is affected by this researching. So thank you so much for sharing, and let's go ahead and.
Well, can I say one more thing? I am so sorry.
Yes.
Listen, we've just got a Humana grant, and we're continuing the UBN, looking at social isolation and loneliness among our elder citizens in Kentucky. Thank you so much. And I'm going to leave the meeting now. Goodbye, everyone.
We're looking forward to hear from this. And now that we have quorum, we're going to go back. The June Board of Health minutes were distributed to the board for the review. Are there any discussions or amendments to the minutes?
Move the adoption.
Let's move to approve. Do I have a proposal to move? Ms. Margolis?
Yep. Yes.
Do we have a second? Dr. Randy? Any opposed? Any abstentions? If you are in agreement, please raise your hand and say aye.
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 So the minutes are approved as they were distributed. Thank you very much. Now we will continue with our agenda, and we go to the mayor's office update. And now I yield the floor to Deputy Mayor Nicole George. Deputy Mayor, I yield the floor to you.
Thank you, Chair, and good morning, everyone. A couple of things I would just say from the mayor's office perspective. We want to give a big congratulations to the 10 public health officers that were sworn in last week. These folks will be covering everything from food safety to tobacco enforcement to lead in facilities. So could not have been more thrilled to see such a great group of dedicated public servants. So that's the good news there. From the mayor's office, I'm working with both the health department and code enforcement and our Office of Housing to try and better coordinate efforts around Let's Safe Louisville and enforcement of the new ordinance. We recognize we have a lot of work to do in this space. Family Health Center has been a strong resource for us in understanding. And so some concentrated work will be happening in that way in the next couple of weeks. Also, Mayor and team here as part of our crime plan is really looking to work with the health department as well as, again, collaborative agencies around ensuring compliance with massage spas. So we have recently devoted a lot of efforts to that, and some really good work is happening on that front. So those are the updates from the mayor's office, and I'm happy to be here. Thank you.
Thank you so much, Deputy Mayor George, for that update, and go team. Teamwork is what makes the difference. Thank you so much. For the director's update, we have, and now I yield the floor to Louisville Metropolitan Health and Wellness Chief Health Strategist, Ms. Connie Mendel.
Patricia, I'll take it. Connie couldn't join us. So
Okay.
as Deputy Mayor said, we just sworn in 10 people. I could tell you we can use many more. So our department, Kelly is on this call, Kelly Monahan and Kathy Turner. And you guys been hearing all the news around grocery store inspections. Just to put things in perspective, our department inspects 4,600 food establishments twice a year. And that includes 947 grocery stores. So there's a lot of work that goes on, and Kelly and her team gets great credit for that. They do a wonderful job. And then Kathy Turner has been very busy for the last couple of weeks, as you guys heard, about some grocery store fiascos, and they're working diligently to alleviate that problem. So our neighborhoods, our people are safe, and they have safe food. They're also inspecting over 100 plus summer nutrition programs run by JCPS, where kids who don't have access to healthy food during summer, because they access food during school years at the schools. So JCPS run this program. There are 100 plus places, and we're inspecting those two to keep our communities safe. And you guys are hearing and will be hearing, again, credit to Kelly's team, a lot of mosquito fogging, and they have a very robust program where they go sort of larvicidal and then mosquito killing and trying to keep us all safe from all those vector-borne diseases. And the report is with you guys, it's attached. The only other thing I'd like to mention, sometimes we don't see quick results from the actions that we take. Our first tranche of opioid abatement funds was used to save lives. And that was about 2.5, 3 years ago. And we are seeing there's a 32% decrease in fatal overdose in Jefferson County in 2024. And among our Black community, which had been sort of trending the other way, is trending right way now, 37% decrease in overdose. And that's all due to effort of Global Metro Public Health and other community partners trying to focus on saving lives. So a lot of credit to our team and our community partners. And I'm open for any questions.
Thank you, Dr. Singal, Executive Director for Leon Metropolitan Health and Wellness. Any questions for him? If not, thank you so much. Appreciate it. Now we go to family health centers. I now yield the floor to Dr. Bart Irwin. Dr. Irwin.
Yes, thank you. I wanted to give the board a brief update on the impact of the proposed federal budget on community health centers. Nationally, there are about 15,000 community health center sites. We serve about 32 million persons per year. Now, Louisville has 3 community health centers. There's Park Duval, Shawnee Christian Health Center, and Family Health Centers. Together, we serve about 55,000 individuals a year. Roughly 28,000 of those individuals have Medicaid. Currently, federally qualified health centers the good news is community health centers will be flat funded for their direct funding from the federal government in the upcoming budget. So that's the good news. The scary news is that what will really devastate community health centers across the country is the reduction in Medicaid recipients. About 70% of our funding, our revenue, comes from Medicaid. And that's not only the reimbursement from Medicaid we get for treating patients, but it also is the margin that we make through our pharmacies and providing medications to Medicaid recipients. So it's what I'm calling the double whammy. First, Medicaid recipients will lose their Medicaid. Community health centers will lose the revenue that we need to not only serve the Medicaid population, but the uninsured as well. And then we will have to cut programs and probably reduce the number of sites we have. So patients not only will lose their Medicaid, they will also lose their source of health care as well, which is really scary. A recent analysis estimated that the number of insured patients will rise from 18 to 35% in community health centers. Family health centers is already at 25% uninsured rate. So we expect that to increase dramatically if the budget passes as it stands now. Health centers will also suffer a decrease in ability to serve patients by 30%, and likely 40% of the health center sites will close across the country. So while there's still time, family health centers, and I hope you'll join with us if you haven't been already, advocate that Medicaid cuts be refused or mitigated to a great extent. The federal budget bill is back in the House now, and so please continue to try to contact your legislators to advocate for no cuts to Medicaid.
Worrisome news. Thank you so much for sharing, Dr. Irwin. Now I share the yield. I yield the floor with Ashley Shoemaker for healthcare coverage and outreach. Ashley?
We're unable to hear you. We're still unable to hear you. Still unable.
Maybe get closer to the computer?
Now?
Yes,
Now.
ma'am.
Okay.
Great. So just to add on to what Dr. Irwin said, the Senate version of the bill that was passed yesterday, it actually takes the Medicaid cuts even further than what was in the House version. The Senate version would include Medicaid work requirements, not only for the non-disabled childless adult, expanded Medicaid population, but also for parents with children over the age of 13. And it also removes Medicaid eligibility for many immigrants, including refugees, asylees, and other groups that have humanitarian status, in addition to removing marketplace tax subsidies for those same groups of people. So many lawfully present immigrants who are eligible for healthcare coverage today would no longer be able to even purchase insurance unless they were able to obtain coverage through an employer. So the current version, it goes even further than those cuts that were in the House. Our Coverage and Outreach Coalition, we met on June 9th and discussed the budget reconciliation bill in detail. We also discussed Medicaid renewals for children, which are currently ongoing. So, just to add on to all of the confusion about what's happening with this budget bill, children are now, having to renew their Medicaid coverage. So that is also ongoing. And our next meeting is scheduled for August 11th at 4 o'clock.
Thank you very much, Ashley. Does anybody have a question for her? If not, thank you. Thank you, Dr. Irwin. Thank you, Ashley. Now, Dr. Ruth Carrico with Immunizations Advocacy Committee doesn't have any updates. We go to our community advisory board we have for JCPS Health. Now I yield the floor to Dr. Everstone. Dr. Stone.
I don't have a lot to tell. Our new superintendent started yesterday, Dr. Yearwood. I have not met him yet, but he is on board and coming at an interesting time in the education world and the healthcare world, as was mentioned a few minutes ago with all that's happening with Medicaid. My only other update is that our nurse practitioners and school nurses did I call it being on tour, but we do clinics around the city for 2 weeks in June. So from June 9th until June the 20th, we were at different high schools around the city offering free physicals and offering immunizations. We did 771 physicals. And so let me tell you, there is no doubt there is significant need. Families do not have access to the care that they need. Parents were really grateful. I don't know if you got to see any of the media with that, but it was really good. We also were able to administer nearly 150 vaccinations. So great. Overall, I'm just incredibly proud of the work our nurse practitioners did and our team did getting those clinics held. And we're just gearing up. School will start. I think it's August the 9th is the first day for students. And so we'll be off and running.
Thank you so much, Dr. Stone. Appreciate it. Now we go to Greater Louisville Medical Society. Now I yield the floor to Dr. Jeffrey Goldberg, incoming Vice President for the Greater Louisville Medical Society representing them for Louisville Metro Board of Health. Dr. Goldberg.
Good morning, everybody. Thank you, Dr. Batista. Pleasure to be here. Thank you for having me at your meeting. Just a few announcements. First of all, as of June 1st, we do officers at the Greater Louisville Medical Society. I'll be the representative of the board as the new vice president. Dr. Tom Higgins is our new president, ENT, and Dr. Anita Badia, who you know is the representative from the prior year, is our president-elect. She will assume the presidency next June. We'd also like to officially welcome our new class of medical students. That'll be the class of 2029 with the white coat ceremony that is being held on July 27th. I believe that's at the Kentucky International, and it's open to the public. We're very excited. I've had the pleasure of working with our first and second year medical students over the last year. And I know there's tremendous enthusiasm among that group for public health and social advocacy, and I assume the next class will continue with that. We do remain very concerned about physician workforce issues. Just as with nursing, we're dealing with an aging physician workforce. We're dealing with ever increasing rates of burnout. Some of this a legacy from the COVID pandemic. We're seeing ongoing barriers with electronic health records, and in particular, ongoing insurance hassles, particularly with prior authorization. And all this is collectively leading to increasing numbers of physicians who are either looking at quitting, or cutting back on their activities. And in the face of all that, unfortunately, we're working with very limited data. Much of this is anecdotal. But I can tell you anecdotally, particularly in my field, which is obstetrics and gynecology, we are having tremendous difficulty recruiting new OB/GYN residency graduates to the state in general, and in Louisville in particular. Unfortunately, I don't see that abating anytime soon. As part of the counter to this, Dr. Higgins, over the coming year, is going to focus on building a sense of community within our physician workforce. Many of the things that traditionally have tied our physicians together in a supportive manner, such as just having access to a doctor's lounge, or when people used to make rounds in the hospital before going to their office, many of those things are no longer a common part of our current healthcare delivery system, and it's led to an increasing sense of isolation among physicians. So we're going to work to counter that by building a sense of community among our physician workforce in town, and I will keep you updated as the year progresses. And that's all I have to report. Happy to take any questions.
Do we have any questions for Dr. Goldberg? If not, thank you so much, Dr. Goldberg. Looking forward for this year.
I do.
Oh,
I do.
Dr. Singal,
Yeah.
go ahead.
Hi, Jeff. Thank you for the report. I just have a quick question. So there are a lot of states that have been implementing a model of attracting medical providers from other countries, of course, vetting them to make sure that they have the skill levels that we desire for our communities, but bypass the arduous, need for 3 more years of residency or 4 more years of residency. They tend to work under supervision. Our neighboring states are doing it. So question is, why are we in Kentucky have not been able to do 2 things? One, we don't even need to design a program. We don't need to reinvent. We can pick one that works, number one. Number two, why are we not a tort reform state? What stops us from getting there to attract talent here?
In a word, inertia. Part of it is our legislative process. For better or for worse, our legislature only meets either 30 days or 60 days a year. And one of the roles I fill is I'm also the legislative liaison for the Kentucky chapter of the American College of OBGYN. So every legislative session, I get to watch the process of, what starts out as well over 1,000 bills that are introduced, gets winnowed down to maybe a few dozen that actually make it to the floor to get voted on. And without taking up too much time, I'll just say that there are lots and lots and lots of great ideas that people will submit as bill requests, and the vast majority of them unfortunately never make it to even a committee hearing, let alone actually getting to the floor. So a lot of this is just continual advocacy, and I think this is something that we can do as public health advocates, is just making sure that this issue kind of rises to the top of people's attention. As you pointed out, there are lots of other states that are doing this. I think if you presented it to many legislators, they would say that sounds like a great idea. It's just a matter of competing with other priorities for attention. There's only so many days in the legislative session. So my suggestion would be to advocate and keep advocating, and recognize that sometimes this is a several-year process to get innovative things like that through the legislature. But I don't think there would be a lot of opposition.
Roger.
Thank you.
Thank you very much, Dr. Gilbert, Dr. Singal. Now we go to the Kentucky Nurses Association. Ms. Manson.
Good morning. Delano Manson for the Kentucky Nurses Association. We just had our national meeting in Washington, D.C., and we had about 500 nurses who visited our legislators to talk about, as everyone else is talking about, is Medicare and Medicaid and access to care, and the possibility that if the bill passes as it is written, that we will have approximately 35 rural hospitals that may have to close. And so we're very concerned about what we can do to encourage our legislators to address those issues. We are getting ready to offer scholarships for nursing students. So if you have nursing students in your sphere of influence, please encourage them to apply for our scholarships. We have our 1 day of giving for the Kentucky Nurses Foundation, which we use that money for scholarships. And we're also doing a 5K run to raise money for the Kentucky Nurses Association. Our annual conference is November the 14th, and our Leadership and Legacy Gala is November the 13th. Both will be in Louisville. So we continue to address the nursing shortage. And we do that through trying to provide those scholarships, but also to elevate the image of nursing so that nursing is a profession that people want to join. And that's all that I have to share for the Kentucky Nurses Association. Oh, one other thing. We will be focusing again on workplace safety as a major legislative effort. And workplace safety is not just for nurses, but workplace safety for healthcare professionals. And for the 2026 legislative session, we will be asking for help from all areas of healthcare to support our efforts to ensure workplace safety.
Thank you very much, Ms. Delano Manson. Does anybody have any questions for her? If not, thank you so much. We don't have a representative for Greater Louisville. Is there any old business that we need to go or to talk about? We have Ms. Maria Marta Sanchez. Do you want to share with us, Ms. Sanchez?
Yes, Madam Chair, thank you.
Mm-hmm.
And I think probably this has been addressed before, but my question to the board is, are we prepared to address the consequences of the present immigration policies and everything having taken place in the nation? Have we thought about how this might create a potential health issue, a public health issue within our communities? And I'm not just talking about access to medical services, I'm talking about depression, vicarious trauma, things of that nature. And I speak also from my personal experience because I do tend to speak to community members and they are very afraid of what's coming down the pipe. And I've experienced vicarious trauma. And I know that as a person, part of the community, common sense is to also have self-care. But there's just so much that I think that individually and even as a group, as a member of groups, it is so much. And my concern is that are we prepared? Because I think that we haven't dealt with something this big before.
Any comments or responses to Ms. Sanchez's question, comment? I can share working with a community organization that accompanies this community that has been greatly affected, that we are trying our best to share about Know Your Rights, and we will have a representative for the 988 crisis line for September. And for now, that's a good way to guide our community who are confronting crisis. They are a good way to, it's anonymous phone call that will get some kind of listening ears and some kind of mental support. So we'll talk about this in September, but this is a good way to remember and to share this number. 988, it's a crisis line, and it's available 24/7. And we are not prepared for this. I think every single organization and every single group is trying to do the best to be as prepared as we can. Anybody else? Is there any new business?
Is there any central resource that would have planning documents or I guess confrontation documents that would be available if a ICE situation were to occur? As far as what the protocol to use or how to handle it. I mean, we have some things at the family community clinic that we've gone over, but is there a central resource for this or a model that could be used?
I don't know about a central resource. I do know that 7 counties in the immigration service is a law enforcement service, just like any other law enforcement service. We face these kinds of questions, even if the Louisville police show up at our JDAC facility to issue a warrant. We still have to interact with them in that capacity. Our response is to deal with ICE in no different way than we would the FBI, the DEA, the state police, the Louisville Metro Police, and because honestly, what we don't want to do, and you all do what you feel like is best, but I would advocate that it doesn't necessarily serve public health to find ourselves in conflict with law enforcement, even personally.
Exactly, right.
Even if you have personal opinions, one way or the other, most of us here receive taxpayer dollars, and we have to walk carefully. There's pretty sound commentary about how healthcare organizations and social service organizations must protect PHI and patient privacy, and so we ask for the proper legal documents, and we don't provide access just because they again, just like any other police officer, we don't make a distinction one way or the other. So that's just our response. I think it's a great conversation to have because it's unknown territory for all of us.
Right.
Thank you, Dr. Hedges. Ms. Margulies?
You're muted.
You're muted.
Is this good?
Yes.
Yes.
Sorry. So 7 counties is a great choice. It just needs to somehow be publicized, not publicized, but that people know the process for doing that, because and not make up something or whatever. There are channels here, and it's just making people familiar with it. And I would encourage sending people to what, and I always mess up, but there is a Metro United Way number that people can call. It's their 1-800 whatever. That might be 888 or whatever it is, to get specifics. But I would not bring right now anything out publicly because of the political ramifications, the media focus, etc. This is, as Maria said, this is incredibly fragile.
And I support what
And
Dr.
especially our
Hedges.
issues with the police. So anyway.
Thank you, Ms. Margulies. I support 100% what Dr. Hedges has just mentioned. Never confrontational, always abiding by the law, and it's always the same response as in any other situation. I wonder if Deputy Mayor Nicole George, do you have any advice or any comment?
I think largely what I have heard is consistent, which is trying to strike a balance, both in the way of support, but again, understanding everyone's roles, being really clear with what those are, and working together.
And
Thank you very much.
I don't want to belabor the point, but the flip side of it is at least in 7 counties, and my hunch is that this is probably true for many of the organizations that are on the board represented at the moment, is that, I sound like such an old guy when I talk like this. Please forgive me. But I've been in public community behavioral health for 30 years, and I've seen the winds of political change go one way or the other, back and forth. And my objective is to foster good working relationships. And I look at other relationships with the police, like the CIT team. We want to continue to foster those. So my advocacy for the Board of Health is, where we can, we look for ways to build bridges, and respecting that the objectives that law enforcement may have are not the same as the objectives that healthcare may have. And we want to strive to figure out ways to build bridges. And in areas that we can't build bridges, we just want to make sure we're not breaking the law. That's my thoughts.
Thank you so much. Thank you so much, Dr. Hedges. Always abiding by the law. Appreciate everybody's participation and for taking time to participate in this month's meeting. If we don't have any other business to deal with, the next meeting will be held on Wednesday, September 3rd at 8 a.m. Remember, we won't have a meeting in August. Summer break, yay. And it's going to be also a virtual meeting. If there is no further business, this meeting is officially adjourned. Thank you very much. Have a beautiful
Thank
day.
you to everyone.
Thank
Happy
you.
4th.
Have a safe and
Thank
healthy
you.
summer.
Yes.
Happy 4th of July, everybody.
Thank you.
Thank you so much. Appreciate it.
Dr.